So this is our Introduction to Pharmacology lecture. This course is about understanding medications at a systems level. So we go through all of our courses organ system by organ system, and that's how we'll also go through, for the most part, our medication classes. As PAs, we'll prescribe, monitor, explain medications every single day. And so pharmacology is designed to give you the tools to understand why drugs work for one patient but not another. Why does a medication cause side effects? Why is this drug dangerous for kidney or liver disease, for example? So these are the course objectives for week one. And after week one, you'll see that the course objectives pretty much repeat themselves. First, we're going to learn some of the basic definitions in pharmacology. And by the end of the course, you should be able to have a better idea about how to predict drug side effects, how to anticipate side effects of a medication, how to recognize unsafe combinations of drugs or drug foods, and how to communicate clearly to your patients what medications they're using and when and how. Okay, so some basic definitions here. Pharmacology is the study of substances that interact with living systems through chemical processes. Medical pharmacology, which we will focus on, is the science of substances used to prevent, diagnose, and treat disease. Toxicology is a branch of pharmacology that deals specifically with the undesirable effects of chemicals on living systems. So that would be individual cells all the way up to humans and complex ecosystems. Pharmacokinetics and pharmacodynamics are essentially what the drug does to the body, and pharmacokinetics, what the body does to the drug. And every drug question you encounter can usually be tracked back to either pharmacodynamics or pharmacokinetics. And we'll talk about these in more detail coming up. So starting off with pharmacodynamics. Pharmacodynamics focuses on the mechanism of action, which is how the drug works, receptor binding, the lock and key interaction that we'll see with most medications, drug potency and efficacy, therapeutic and toxic effects. So PD explains both the intended therapeutic action, so what we are hoping will occur when we give a patient a medication, and the side effects. And it's all about how drugs cause the changes in the body. So it's the mechanical explanation for why a medication actually treats the disease we are intending to treat and why it can cause side effects and adverse reactions. So we'll answer questions through pharmacodynamics like, why does a certain medication lower the blood pressure? Or why does it cause dizziness? Or why does it stop working over a longer period of time? So overall, this is going to help us predict desired effects, side effects, and drug interactions at the receptor level. So on this slide, we're looking at a very basic but a very important question, which is how do drugs actually change what the body is doing? And so at the core, anytime we give a patient a drug, it works by altering normal physiologic processes. And there are only a few major ways that medications do this. The most common mechanism you'll see kind of throughout this course is a receptor activation or blockade. So receptors are proteins, and they can be located either on the cell surface or inside the cell. When a drug binds to a receptor, it either turns a signal on or prevents a signal from occurring. So clinically, this explains why when we block a receptor, we can, for example, lower heart rate or reduce blood pressure or stop pain signals because you're interfering with a normal physiologic signaling pathway. Another major mechanism is enzyme inhibition or activation. So enzymes speed up chemical reactions in the body. And so if you block an enzyme, you slow down that process. The classic example is our NSAIDs, so our COX inhibitors, which would be like Celebrex, leading to decreased prostaglandin production. And we've talked about prostaglandins kind of across all of our conditions up to this point. And so clinically, this explains both their benefits, like pain and inflammation reduction, and their side effects such as GI irritation, because prostaglandins normally protect the stomach lining. So this is kind of a high level example of how side effects and desired effects interact based on the mechanism of action. Okay, and then drugs can also work by modulating ion channels. So ion channels control the movement of charged particles like calcium, sodium, potassium across the cell membrane. So Calcium channel blockers are an interesting example for this. They reduce calcium entry into cardiac cells, for example, which reduces cardiac contractility, so the strength of the systolic function of the heart. Clinically, this is why these drugs would affect heart rate, blood pressure, and cardiac workload. Another mechanism we look at is transporter effects. So transporters move substances across cell membranes, and SSRIs are selective serotonin reuptake inhibitors. They block serotonin reuptake transporter, which increases serotonin levels in the synapse. So clinically, this helps explain why SSRIs take time to work and why they cause side effects related to serotonin access. And then some drugs work through direct chemical or physical action, so without receptors or enzymes at all. So antacids are a good example of this. They simply work to neutralize gastric acid in the stomach. And clinically, this is why antacids work quickly, but don't change acid production long term, because they are really just a localized effect. And so I know this is a long slide, but the big takeaway is that while drugs seem very different, most medications fit into one of these mechanisms. And so having a good core understanding of these mechanisms will help you over time predict effects, side effects, and interactions. Okay, so let's revisit receptors. As we said, most drugs produce their effects by interacting with receptors to cause a response. So receptors, again, are specialized proteins whose normal job, normal physiology, is to recognize signaling molecules in the body. So these would be things such as neurotransmitters or hormones circulating throughout the body. And then when we introduce a medication, our medications work by essentially mimicking or blocking those normal signals. So the interaction between a drug and its receptor follows what we would call a lock and key model. So the drug is the key and the receptor is the lock. And in general, the better the fit, the more predictable the effect. So when we look at the different types of receptors, and keeping in mind that there are several major types and the type matters clinically. So ligand-gated ion channels, these act very quickly. So when a drug binds, the channel opens or closes almost immediately. So an example of this is benzodiazepines, something we use for acute anxiety. They work on a GABA-A receptor, which is why their effects are very rapid. G protein-coupled receptors, these are extremely common. These are used in many autonomic drugs, so our autonomic nervous system drugs, and these involve second messengers, so they are a little bit slower, but still fairly fast. Enzyme-linked receptors, these are things like insulin receptors. So these trigger an intracellular cascade, and that changes the cell behavior over minutes to hours. So we're kind of getting a little slower in our onset as we work our way through the slide. And then our intracellular or nuclear receptors. So these are things like steroid receptors. These work by altering gene transcription. So if you can imagine, altering gene transcription is a longer process. They have a slower onset, and they do have a slower onset, but their effects tend to last longer. So that's something we keep in mind when we talk about steroids. So overall for the slide, the key takeaway is that the receptor type determines how fast a drug works, how long it lasts, and how strong the response will be, which is why understanding the type of receptor is central to pharmacology. So this slide is just kind of giving you a visual of what we just talked about in detail for the different type of receptors. Okay, so these four terms describe how a drug behaves at its receptor, and they're easy to mix up, so let's kind of separate them clearly. Affinity refers to how strongly a drug binds to its receptor. So a high affinity drug can bind effectively even when there's only a very small amount of drug present. Clinically, this helps explain why some drugs will still have effects at very low concentrations. Efficacy is the maximum effect a drug can produce, regardless of dose. So this is what determines whether a drug is actually useful clinically. And even if a drug binds well, if it has a low efficacy, it can only do so much. Potency refers to the amount of drug needed to produce an effect. So a more potent drug achieves the same effect at a lower dose. Importantly, more potent does not mean better or safer. It just means less drug is required. And then finally, selectivity describes a drug's preference for one receptor over others. So higher selectivity usually means fewer side effects because the drug is less likely to activate or block unintended receptors. So key takeaways here is that these terms describe different properties of drugs, and understanding them will help us predict their effectiveness, their side effects, and their clinical usefulness. Okay, so this slide introduces agonists, which are drugs that bind to receptors and activate them to produce a response. So when an agonist binds, it essentially turns the receptor on, and that would mimic the body's natural signaling molecules that occur in normal physiology. There's several types of these agonists. Full agonists produce a maximal possible response from a receptor. So for example, albuterol, which we use for asthma, fully activates beta-2 receptors, which is why it can strongly relax airway smooth muscles and improve the airflow. Partial agonists also activate receptors, but they produce a weaker response. So even when all receptors are occupied, they'll still have a weaker response if it's a partial agonist. Good example is buprenorphine, which we use in opioid therapy. So clinically, this limited effect of this medication is why partial agonists are often safer, because they reduce the risk of excessive receptor activation, for example, respiratory depression overlap. And then inverse agonists, we go a step further. So instead of blocking the receptor, they reduce the receptor activity below its normal baseline level. So some antihistamines work this way, which helps explain both their therapeutic effect and certain side effects. The key takeaway is that not all agonists are equal, and how strongly they activate receptors matters both for their efficacy and their safety. Okay, so next we're looking at antagonists, which are drugs that bind to receptors but do not activate them. So unlike agonists, antagonists do not turn the receptors on. Instead, they block the receptor, preventing the normal physiologic signaling from occurring. We have two main types of antagonists. Competitive antagonists bind reversibly to the receptor. This means they compete with agonists for the same binding site, and their effects can be overcome if enough of an agonist is present. That's where that competitive term comes in. Non-competitive antagonists bind irreversibly. So once they attach to a receptor, that receptor is essentially taken out of service until the body makes new ones. So this is very important physiologically. The overall effect of antagonists is that they prevent agonists from binding. So that leads to a decrease in the normal physiologic response. And this is how many of our common drugs work. For example, beta blockers, they block the beta receptor, which lowers the heart rate, reduces the cardiac workload. Naloxone, which reverses opioids, that blocks opioid receptors, rapidly reversing the effect of opioids during an overdose. So key takeaway is that antagonists are critical for controlling excessive physiologic activity and for emergency reversal of drugs. So in this slide, this kind of compares the reversible versus the irreversible antagonist. And so where this can become important is with overdose reversals. So if you think of a competitive antagonist, that can be displaced because it's reversible by agonists and antidotes. And then our non-competitive antagonist cannot be replaced. So that reversal requires, again, new receptors to be turned over. So very important for the irreversible is we have this long-term blockade and medications can become more poisonous to the body, more difficult to reverse if someone's having an adverse effect if they are a non-competitive irreversible antagonist. So overall, it's a greater clinical challenge because once they bind, again, the receptors are permanently inactivated. Their effect cannot be overcome by increasing the agonist concentration. So the drug effects basically persist until new receptors are synthesized by the body. So longer lasting physiologic suppression, limited reversibility, and increased risk of toxicity or overdose. Okay, so downregulation and tolerance. This slide highlights why the body adapts to chronic drug exposure. So with repeated use of certain drugs, especially agonists, the body essentially tries to restore the normal physiologic balance. And one way it does this is through downregulation. So downregulation means that the number of receptors decrease over time when a receptor is continuously stimulated. So fewer receptors means less response to the same amount of drug. And so as a result, we often see, as a result also of chronic use, we often see tolerance. So this is where increasing doses are required to achieve the same effect. The drug hasn't changed, but the body response has. And you will see this commonly with opioids, benzodiazepines used for, again, anxiety conditions. And then our classic one is nasal decongestants, especially our over-the-counter Afrin type medications, which can lead to this rebound congestion called rhinitis medicamentosa, which is the body's response when they stop using it. So clinically, this matters because chronic use of agonist drugs often leads to a dose escalation, so more of the medication over time. And then this is where we have to start thinking about patients being dependent, toxicity, and overdose. So takeaway here is that the tolerance is a predictable pharmacologic response. So we do know with certain medications that tolerance is going to occur. This is not a patient failure for taking the medication incorrectly, but it does help us predict what medications are going to be safe and how we need to monitor them. So then we have the dose-response relationship, which shows how changes in dose affect the magnitude of the drug's effect. So the dose-response curve, which I believe is shown on the next slide, will help us visualize some of these ideas. So the first is threshold dose, and that is the minimum dose needed to produce a measurable effect. So below this level, the drug may be present in the body, but the patient will not have any clinical response. The next is slope of the curve, which this reflects how responsive the system is to changes in the dose. So a steep slope on the picture on the next slide means that small dose changes cause large changes in effect, which can increase the risk for side effects. So that's a steep slope. And the opposite would be true if it was a more of a gradual slope. It would be larger dose changes needed to see larger changes in the effect. Okay, and then on the next slide, we'll see the curve, and the top of the curve is what we call Emax, or maximal efficacy. And this represents the greatest effect that the drug can produce. No matter how much more drug you give, Emax is how effective, maximum it can be effective. So once we have reached Emax, increasing the dose will only increase the toxicity and the side effects. It will have no other benefit. And then finally, we look at the potency shift. So this is basically a visual representation on the curve of how potent the medication is. So if the curve shifts to the left, the drug is more potent, takes less drug to achieve the same effect. If it shifts to the right, the drug is less potent. So takeaway here is that potency changes the position of the curve horizontally, as I just said, and then efficacy changes the height of the curve. And then both of these two together predict the drug behavior and the safety. Okay, and then here we can see that drug A is more potent than drug B because it is further left, but they both have the same efficacy. And then we see that drug C shows lower potency because it is further to the right and lower efficacy than drugs A and drug B. And also, if you look at this slide and listen to the last slide at the same time, you can get a kind of a better idea of all of these visually represented. Okay, so on this slide, this is how we think about drug safety margins. So how close a drug's helpful effects are to the harmful effects. And the first term is ED50, which stands for effective dose in 50% of the population. This gives us a sense of how much drug is needed for a typical effective therapeutic benefit. The next is TD50, which is toxic dose in 50% of the population. This tells us at what point side effects or harmful effects start becoming common. And then there is LD50, which is lethal dose in 50% of subjects. And this is based on animal studies, not human trials, but this value is used for safety comparison and drug development, not for clinical dosing. So together, these values define a drug's safety dosing window, which we're going to talk about next, and that is the range where the drug is effective without causing harm. And clinically, the farther apart the effective dose and the toxic dose are, the safer and more forgiving the medication is. Drugs with narrow safety margins require closer monitoring and greater caution. So continuing on that theme, we are looking at a very practical question, which is how safe is a drug relative to its benefit? So we use a concept called the therapeutic index, or TI. A therapeutic index is calculated by the TD50 divided by the ED50, or in other words, how close the toxic dose is to the effective dose. So a wide therapeutic index means that we have a wide, large gap between the effective and toxic doses. So that means these drugs are generally safer and more forgiving to use. Examples of these would be penicillins and SSRIs, where we have small changes in the dose and that is unlikely to cause serious harm. A narrow therapeutic index means that the effective dose is close to the toxic dose. So with these drugs, small changes in dose or small changes in absorption or metabolism, such as how is our kidney and liver function, this can lead to toxicity. And examples would include warfarin, lithium, digoxin, carbamazepine. Because of the more narrow therapeutic index and their risk, these drugs require extra care. So they need lab monitoring, they need dose adjustments, and they need more patient education. So this helps us anticipate which drugs require closer monitoring and more caution, even before we consider patient-specific factors such as. So now we're looking at another pharmacologic principle, which is selectivity and how that affects side effects. So the more selective a drug is, the fewer unintended effects it tends to have. So highly selective drugs act primarily on one specific receptor type. And because they target a narrow pathway, they are less likely to affect other body systems, which usually means fewer side effects. So in contrast to that, a non-selective drug tends to bind multiple receptor types. And so while this might still give us the desired effect therapeutically, it often leads to additional unintended physiologic responses in different organ systems. And we recognize these clinically as side effects. So classic example is diphenhydramine or Benadryl. And although it's used for allergies, it also binds muscarinic receptors, which explains side effects like sedation and dry mouth. And by comparison, we have these second generation antihistamines that are more selective for just the histamine receptors and have much less activity at other receptors, which is why they cause less drowsiness. So key takeaway here is that selectivity helps predict tolerability. And the more narrowly a drug targets its receptor, the more predictable and manageable its side effect profile will be. Okay, so on this slide, we're going to revisit two high yield concepts. And these are sometimes mixed up, and that's potency and efficacy. So potency refers to the amount of drug required to achieve a given effect. So a more potent drug reaches the desired effect at a lower dose. But importantly, potency does not indicate superiority. It does not tell you how strong the final effect will be. Efficacy, on the other hand, refers to the maximum effect a dose can produce. The maximum effect a drug can produce, no matter how much you give. And this determines its clinical usefulness. So you can give huge amounts of a drug, but a drug will max out on its efficacy. And if a drug cannot achieve the desired effect, increasing the dose won't fix that, right? So because these are independent properties, a drug can be very potent, but have a very low efficacy, or a drug can be less potent, but be highly effective. So a classic example is morphine and meperidine. These have different potencies, meaning that different doses are needed, but both are capable of producing analgesia because they both have sufficient efficacy. So potency affects dose, but efficacy determines whether the drug can do the job at all. So what happens when we put drugs together, when drugs are used at the same time? And this, of course, happens very commonly in clinical practice. The first type of interaction is what's called an additive effect. And that is where 1 + 1 = 2. So each drug contributes its expected effect, and the total response is predictable. So an example is acetaminophen or Tylenol being combined with ibuprofen. They work through different mechanisms, but together they provide greater pain relief without amplifying toxicity when used appropriately. So next is synergistic effect, where 1 + 1 is greater than 2. And so here the combined effect is much stronger than expected. Classic and dangerous example is alcohol combined with benzodiazepines, which can lead to severe respiratory depression. And so clinically, this is one of the most important combinations to recognize because it seriously increases the overdose risk. And then third is an antagonistic effect, where one drug reduces or blocks the effect of another. So naloxone, as we talked about before, is a key example. It antagonizes opioid receptors and can reverse opioid overdose by blocking the opioid effect. So the takeaway here is that drug combinations can either enhance benefit or dramatically increase harm, and understanding these drug-drug interactions is essential for preventing our adverse events, our side effects, and improving our overall patient safety. Okay, so let's try to put some of our pharmacodynamic concepts together using albuterol. That's an inhaler we use for asthma as a clinical example. So albuterol is a beta-2 agonist with a high affinity for beta-2 receptors, meaning it binds effectively to the receptors found on airway smooth muscle, even at relatively low concentrations. Albuterol also has a high efficacy, meaning once it binds, it produces a strong physiologic response specific for bronchodilation, and this is why albuterol is effective for rapid relief of bronchospasm. Albuterol is also relatively selective for beta-2 receptors, so it preferentially targets beta-2 rather than beta-1, which you may or may not have remember from physiology, is more of a cardiac effect, and so because it is more selective for beta-2, it tends to have minimal cardiac effects, such as tachycardia, when compared to other less selective agents. However, chronic or excessive use of albuterol, we can see partial loss of its effects. And this occurs because of downregulation. The body will reduce the number of beta-2 receptors in response to repeated stimulation or repeated use of albuterol. So clinically, this is an example of how affinity, efficacy, selectivity, and tolerance all interact. to determine both the effectiveness and the limitation of a drug. Okay, let's talk about pharmacokinetics. Okay, so this slide introduces pharmacokinetics, which remember we describe as what the body does to a drug. And we organize pharmacokinetics in 4 basic steps: A, D, M, and E: absorption, distribution, metabolism, and elimination. Absorption refers to how a drug moves from its site of administration into the bloodstream. This can happen very directly with IV medications or indirectly, such as with oral medications that must cross the GI tract first. Clinically, absorption affects how quickly and how much drug reaches the bloodstream. Distribution describes how the drug leaves the bloodstream and spreads into the tissues, including the interstitial and the intracellular fluid. And not all drugs go everywhere equally. Some stay mostly in the blood, while others will distribute widely throughout the body, fluids and tissues. This explains why certain drugs will affect the brain or muscles or fat differently. Metabolism is the process by which a drug is chemically changed, usually by the liver, or other tissues and organs can be involved. But the goal of metabolism is often to make a drug easier to eliminate. So we're setting up the process for elimination. And clinically, metabolism explains many drug interactions and why liver disease matters a lot when we are prescribing medication. And then elimination is how the drug and its metabolites are removed from the body. So most common routes of elimination are urine and bile. But drugs can also be eliminated through breast milk, saliva, sweat, tears, and feces. So we have this ADME, and this determines how fast a drug works, how long it lasts, how long it stays in the body, and this is why pharmacokinetics is essential for our safe medication use. So on this slide, we're understanding where a drug is absorbed matters. So first, looking at site-specific absorption. So acidic drugs such as aspirin will be better absorbed where the environment in the body is relatively acidic. So for this example, the proximal duodenum. And basic drugs, example is diazepam, are better absorbed in the small intestine where the pH is higher or more basic. And the reason for this is what we call ionization. So drugs are generally absorbed best when they are non-ionized, because non-ionized drugs cross cell membranes more easily. So next is drug interactions and timing. So medications like antacids or PPIs raise the gastric pH. And so by making the stomach environment less acidic, they can reduce the absorption of acidic drugs. So that may lower that drug's effectiveness. This is also why some drugs have enteric coatings. So these coatings prevent the drug from dissolving in the stomach and allow it to dissolve later in the intestine where the pH is more favorable for that drug's absorption. And then last is ion trapping. So something to keep in mind is that when there are pH differences between compartments in the body, drugs can become trapped in certain areas. So for example, weak bases may accumulate in acidic urine, which is important for understanding drug toxicity and elimination. So continuing with some additional factors that influence drug absorption beyond pH and ionization. So first would be the blood flow to the absorption site. So for example, intestines have a much greater blood flow than the stomach, which is one reason why most drugs are absorbed more efficiently in the small intestine. Increased blood flow, of course, helps carry the drug away from the absorption site, and that maintains a significant concentration gradient. Clinically, this becomes important in situations like shock. So for example, in shock, blood flow is redirected away from the skin, which can severely reduce the absorption that we would normally expect when giving a subcutaneous injection. So even though the drug may be given, in cases of shock, very little of that drug may actually reach the bloodstream. Next is total surface area for absorption. So the small intestine has this massive surface area due to the folds and the brush border and microvilli, which is about 1,000 times greater than the stomach. So this enormous surface area makes intestinal absorption far more efficient. And then finally is contact time at the absorption surface. So if drugs move too quickly, for example, through the GI tract, they will not be absorbed well. So severe diarrhea is going to reduce absorption because there is not enough contact time for the drug to uptake. On the other hand, delayed gastric emptying, this will slow the absorption of medication. So food in the stomach can dilute the drug and delay its movement into the intestine, slowing the onset of action for that medication. So takeaway here is that blood flow, surface area, and contact time all directly affect how much drug is absorbed and how quickly it works, even when the dose is unchanged. So let's look at the P-glycoprotein, which is an important factor that can limit drug absorption. So P-glycoprotein is a transmembrane transporter protein, and its job in normal physiologic process is to move substances out of cells, but this also applies to drugs. So it's helpful to think of it as like a cellular pump that is actively pushing drugs back out after they enter a cell. P-glycoprotein is found in intestines, liver, kidneys, placenta, brain capillaries, and this also has factors, as we'll discuss, the blood-brain barrier. But keeping in mind that when there's high expression of glycoprotein, less drug is absorbed into the bloodstream because the drug is pumped back into the gut or out of the tissues where it's attempting to be absorbed. So clinically, that means that even if a drug is taken correctly, less active drug may actually reach the systemic circulation or the location where it's intending to have its effect. And we hear about P-glycoprotein in multi-drug resistance. So for example, in cancer cells, they express high levels of P-glycoprotein and can pump the actual chemotherapy drug out of the cell, making the treatment less effective. So P-glycoprotein acts as a protective barrier for our body in certain instances, but it can also reduce the drug absorption and contribute to treatment resistance, making it important to understand in general for pharmacokinetics. Okay, so now we're going to look at distribution, which is the process by which a drug reversibly leaves the bloodstream and enters tissues and other extracellular fluid. Distribution does not happen evenly throughout the body, and several factors are going to determine where a drug goes. So first of all, blood flow. Drugs are going to distribute more rapidly to vessel-rich organs. So where blood flow is higher, like the brain, the liver, and the kidneys. Distribution to muscle and adipose tissue is slower because blood flow is lower to these areas. So this explains why some drugs will have rapid effect in the brain, but take longer to balance out in fat or muscle. Next is capillary permeability. And we want to remember that capillary permeability varies by tissue. So the blood-brain barrier is especially restrictive. It limits polar and ionized drug, while it allows lipophilic drugs to pass more easily. And this is why not all medications will affect the central nervous system because of this blood-brain barrier. Another major factor is plasma and tissue binding. So many drugs bind to plasma proteins, such as albumin being probably our most common example. And this temporarily ties up or sequesters the drug. So only free, unbound drugs are pharmacologically active. And then drugs can also bind to tissues, making them pharmacologically inactive. And this also creates reservoirs, and that may, prolong the amount of time that a drug is in the body, prolong its actions, and contribute to toxicity. And then lipophilicity. This is where lipophilic drugs cross cell membranes more easily, such as the blood-brain barrier, we know allows lipophilic drugs to pass. And this means that lipophilic drugs distribute widely, mostly based on blood flow, because they just need an avenue to get there. In contrast, hydrophilic drugs rely on slit junctions and remain more confined to the bloodstream and the extracellular fluid. So this explains why drugs like propofol have rapid central nervous system effects, because they are highly lipophilic. And so they have they can highly pass through membranes. There's a lot of cerebral blood flow. And this is also why tissue accumulation of certain drugs and metabolites can lead to delayed clearance or toxicity of that drug. So keep in mind that distribution determines where the drug acts, how fast the effects are going to occur, and how long the drug may be present in the body. Okay, so bioavailability describes how much of a drug actually reaches systemic circulation and how quickly it gets there after it's administered. So by definition, bioavailability is the rate and extent to which a drug enters the bloodstream in its active form. When a drug is given IV or intravenously, bioavailability is 100%, and that's because the drug is delivered directly to the bloodstream. There is no absorption barriers, there is no initial metabolism it has to undergo. With oral administration, bioavailability will always be less than 100% because we have several factors. So incomplete absorption in the GI tract, the fact that it has to go through first pass metabolism in the liver, so that can lead to inactivating a portion of the drug before it reaches the systemic circulation. And then bioavailability is often calculated using area under the curve, so looking at the image on the right, or AUC, from plasma concentration, what we could call this plasma concentration time graph. You don't need to necessarily calculate this, but just understand that the AUC reflects the overall drug exposure. For example, if a patient were to take 100 milligrams of an oral drug and only 70 milligrams reach the bloodstream, the bioavailability is 70%. So route of administration matters. Bioavailability helps explain why oral and IV doses will differ, why some drugs must be given by specific routes, and why changes in absorption or metabolism can significantly affect drug levels. So what are the major factors that are going to influence bioavailability, or how much active drug actually reaches systemic circulation when a medication is taken by mouth especially? So the first is first pass metabolism. After a medication is given orally, a drug is absorbed from the GI tract and passes through the gut wall and liver via the portal circulation before reaching systemic circulation. So during this first pass, a significant portion of the drug can be metabolized and inactivated. So, for example, if nitroglycerin is taken orally and swallowed by mouth rather than sublingually, more than 90% of it is cleared during first pass metabolism, so it would not be effective. Next is drug solubility. So as we said, very hydrophilic drugs have difficulty crossing lipid cell membranes, so absorption is generally poor. And in contrast to that, very lipophilic drugs can cross cell membranes easily, but keep in mind that these very lipophilic drugs dissolve poorly in aqueous GI fluids. So the most effective drugs that are taken orally generally have a balance between lipophilicity and hydrophilicity. Another factor is chemical instability. Some drugs would be destroyed by the GI environment before they can even be absorbed. So penicillin G, for example, is degraded by stomach acid. Insulin is broken down by digestive enzymes, which is why these medications are generally not given orally. And then drug formulation is also going to play a role. So how a drug is manufactured affects how it dissolves and how quickly it is absorbed. So factors such as particle size, salt form, coatings, excipients, for example, can significantly change the bioavailability. So oral bioavailability is influenced by metabolism, by chemistry, by medication formulation. So that explains why some drugs work well orally and others require alternate routes of administration. So this slide explains the blood-brain barrier, which is a specialized feature in brain capillaries to protect the central nervous system. Capillary structure is going to vary throughout the body. So organs like liver and spleen, the capillaries are large and discontinuous. So their exposed basement membrane has these slit junctions, and these allow large molecules and plasma proteins to pass freely between the blood and the tissue. The blood-brain barrier is very different. In the central nervous system, capillaries are continuous. There are no slit junctions between the endothelial cells. So instead, the cells are very tightly packed together and have very tight junctions. Because of this structure, drugs cannot slip between the cells to enter the brain. To reach the central nervous systems, drugs must either pass directly through the endothelial cells or use an active transport mechanism. So lipid-soluble drugs cross the blood-brain barrier more easily because they can dissolve into and pass through the endothelial cell membranes. In contrast, ionized or polar drugs generally cannot enter the central nervous system because they cannot cross the tightly joined endothelial cells, and there are no gaps to pass through. So clinically, this explains why some drugs have central nervous system effects, while others do not. Certain infections or toxins can be difficult to treat in the brain because we have to make sure the medications can get there. And then drug properties like lipid solubility matter a lot when it comes to the neurologic effects of that medication. So the blood-brain barrier is a structural and functional barrier that very tightly controls what enters the brain and in general prioritizes protection over drug access. So this is just a visual example of what we just said. On the left, we have, for example, a liver capillary. Large fenestrations will allow medications to move between the blood and the interstitium of the liver. In contrast, on the right, we have the brain capillary, and we have these very tight junctions. The cells are merged, and so there is basically a continuous wall that allows protection and tightly controls what enters, again, prioritizing protection over drug access. So the next step in pharmacokinetics is the metabolism and elimination of a medication from the body. So elimination begins as soon as a drug enters the body. We have three major routes: hepatic metabolism, biliary elimination, and urinary excretion. And keep in mind that a constant fraction of drug is eliminated in a given unit of time. So if you're looking on the right and you see that elimination phase, most drugs show an exponential decrease in concentration with time, of course, because as time goes on, we have more opportunity to eliminate the drug. So here we focus on elimination. So the irreversible removal of a drug from the body. Elimination occurs through two processes: metabolism and excretion. Metabolism, also called biotransformation, is the chemical modification of a drug, usually by the liver, but other tissues can contribute to this process. The goal of metabolism is typically to convert drugs into a more polar or water-soluble form, which makes it easier for the body to eliminate. Excretion is the physical removal of the drug from the body, most commonly through the kidneys into the urine, but also this can occur through bile, feces, and other minor routes. Excretion usually removes either the unchanged drug or its metabolites. So together, metabolism and excretion determine how long a drug stays in the body and how long its effects last. And we describe elimination using the concept of clearance, abbreviated as CL. So clearance estimates the volume of blood from which a drug is completely removed per unit of time. Clinically, clearance helps us determine and understand how efficiently the body can get rid of a drug. So elimination controls drug accumulation and duration of action, which is why changes in liver or kidney function will have a major impact on drug levels in the body and the safety of the medication. Okay, so this slide introduces drug metabolism, which again, the overall purpose is to convert lipophilic drugs into more hydrophilic forms so that they can be eliminated by the kidneys. First step in this process is phase 1 metabolism, which is also called functionalization. In phase 1, the drug's chemical structure is modified in some way, so by either introducing or unmasking a polar group, such as hydroxyl or amino groups, and this makes the drug more water soluble, but it does not always make it inactive. Phase 1 reactions include oxidation, reduction, hydrolysis, and they are primarily carried out by the CYP450 enzyme system, or cytochrome P450 enzyme system, which we'll hear a lot about throughout pharmacology. So some of these on the right are especially important clinically. These enzymes metabolize a large number of commonly used medications, so you'll hear about them a lot. Now, within this system, there is genetic variability. So because there is genetic variability in these enzymes, this means that patients can metabolize drugs at different rates. For example, differences in CYP activity affect drugs like codeine and clopidogrel, which is a blood thinner, and this can alter the effectiveness or the risk of side effects for certain patients based on the genetic variability that they have. Now, certain drugs can also affect CYP activity. So, inducers increase metabolism. So remember, metabolism is how we are changing the drug from its active to inactive form, lowering the drug level. So drugs like rifampin increase metabolism, ultimately lowering the drug level. Those are inducers. Inhibitors like ketoconazole or ritonavir slow metabolism, so that can increase drug levels and the risk of toxicity. And this mostly comes into effect when two medications are combined. But you will want to be aware that certain drugs will have warnings that they are either inducers or inhibitors and understand what that means. So phase 1 metabolism is a major source of drug variability and interactions when we used one medication or multiple medications. Okay, so now we move to phase 2 drug metabolism, also called conjugation, which continues the process of preparing drugs for elimination. The overall purpose of phase 2 metabolism is the same as phase 1. We are still trying to convert lipophilic drugs into hydrophilic forms so they can be excreted by the kidneys or the bile. In phase 2, the drug or the phase 1 metabolite has a polar group attached to it. So common conjugates in this would be glycuronic acid or sulfate. These reactions produce compounds that are more water soluble, so highly water soluble, and typically after phase 2, they are pharmacologically inactive. So once conjugated, these drugs are usually ready for renal or biliary excretion. The most common phase 2 reaction is glycuronidation, which plays a major role in clearing many medications from the body. It is also important to know that not all drugs require phase 1 metabolism first. Some drugs already have polar groups and can enter phase 2 directly. So think of phase 2 metabolism as a detoxifying step. It generally inactivates drugs and makes elimination efficient and predictable. Okay, so let's look at renal elimination, which again is the primary way many drugs leave the body. For drugs to be eliminated by the kidneys, they must be sufficiently polar or water soluble. This is why metabolism is so important, because it converts the lipophilic drugs into forms the kidneys can remove efficiently. The kidneys are the main route of elimination for many drugs and their metabolites. So when renal function is normal, drugs are cleared at predictable rates. We understand when they will be cleared. However, when renal dysfunction occurs, drug elimination will be significantly changed, impaired basically, not as efficient. So when clearance is reduced, drugs can accumulate in the body, and this increases the risk of toxicity, even though the dose of the medication has not changed. In clinical practice, when we assess kidney function, we refer to glomerular filtration rate, or GFR. Normal GFR is about 120 milliliters per minute per 1.373 square meters, which is just what will show up on the lab. But this value can decrease substantially in renal disease. So clinically, this is why kidney function is a critical consideration when you're talking about how safe it is to prescribe a medication. Changes in GFR are directly going to affect how long a drug stays in the body. So renal elimination depends on polarity and kidney function. And impaired renal clearance increases the risk of drug accumulation and adverse effects. Okay, so this slide breaks down renal drug elimination into three key processes, each of which are going to contribute differently to how drugs leave the body. So first, glomerular filtration, which we touched on the previous slide. Only free, unbound drugs can pass from the blood into the filtrate. And this process is not influenced by lipid solubility or urine pH. This depends mainly on the glomerular filtration rate, or the GFR, and the degree of protein binding. So drugs that are highly protein bound are filtered less efficiently. Next is proximal tubular secretion. This is an active process that uses transporters for organic anions and cations to move drugs into the urine. These transporters have low specificity, so different drugs can compete with each other, leading to drug-drug interactions. It's important to know that tubular secretion is immature in neonates. So drug clearance in infants is going to be much different. And then the final process is distal tubular resorption. This is a passive process where unchanged drugs can be resorbed back into the bloodstream. And this is where urine pH matters. So by manipulating urine pH, we can use ion trapping to enhance elimination. So alkalinizing urine increases the elimination of weak acids, such as phenobarbital, because it decreases distal tubular resorption, or the reabsorption of the medication back into the bloodstream. And same would happen for acidifying the urine, is going to increase the elimination of weak bases. So filtration, secretion, and resorption together determine renal drug clearance, and changes in protein binding, kidney function, or urine pH will all significantly affect drug level and drug safety. So while the kidneys are the primary route of drug elimination, there are alternate routes of excretion that are also important. So one route is the intestines and the bile, with elimination in the feces. So this might involve an unabsorbed drug, such as a medication that never got out of the GI tract, never fully entered the bloodstream. or drugs that are actively secreted into bile by the liver. So this pathway would be especially relevant for drugs with a significant hepatic metabolism factor. Another route is the lungs. So volatile substances such as our inhaled gases are eliminated primarily through exhalation. So lung function, in this case, would directly affect how quickly the drug leaves the body. So patients with decreased lung function, COPD for example, will not eliminate these drugs as quickly. Drugs can of course be excreted in breast milk. So some drugs and even their metabolites can be passed to infants, potentially causing side effects or toxicity in the infant. So that is why we have a lot of warnings, and medication safety during lactation is very important. And then there's some minor routes of excretion with sweat, saliva, tears, hair. These routes do not have a big clinical impact, but you might think of these as explanations for like drug-related odors, taste changes, or diagnostic test findings that may occur. So while renal elimination dominates the elimination pathway, there are other excretion routes that, again, these are going to affect drug safety, exposure, special population considerations, for example, liver disease and breastfeeding. Okay, so let's try to put this all together for a little bit of clinical relevance. So we're going to try to tie excretion directly to clinical decision making, going back to total body clearance and half-life. So total body clearance or systemic clearance represents the sum of all the processes that we talked about that remove a drug from the body. This includes clearance by drug metabolism and drug eliminating organs. The kidneys are often the major organ responsible for clearance, as we discussed, but the liver plays a key role because of metabolism and excretion into bile. So clearance helps determine how quickly drug levels will fall off and is a major factor in maintaining the effectiveness of a medication while avoiding toxicity. And then closely related to clearance is a drug's half-life. So a half-life is defined as the time it takes for the amount of the drug in the bloodstream to decrease by 50% due to metabolism and excretion. Half-life would help us understand how long a drug lasts in the body and how frequently it needs to be administered. So when something alters a drug's half-life, then drug accumulation will occur and adjustments are then required. So people that may experience increased half-life would be patients with reduced renal or hepatic blood flow. So this is patients such as heart failure, cardiogenic shock, or massive hemorrhage, where not enough blood is getting to vital organs. Patients with renal disease have decreased ability to remove drugs from the plasma. And then decreased metabolism, seen in hepatic insufficiency, cirrhosis, or any drug that inhibits metabolism. So clearance and half-life are terms you will hear a lot, and they are very central to drug safety. Changes in organ function or drug interactions can significantly prolong drug exposure and increase the risk of adverse effects. Okay, moving on to pharmacogenetics. So genetics is how genetics affect drug response. The study of how genetic variation is going to influence drug metabolism, which is pharmacokinetics, drug targets and receptors, which is pharmacodynamics, drug effectiveness, and the risk of adverse reactions. And so the goal with pharmacogenetics is to personalize therapy for safety and effectiveness. But it also helps explain to us why certain patients respond differently to the same drug in the same dose. So why is pharmacogenetics important to clinical practice? The same dose will not work the same for every patient that you encounter. So why is it that the same drug dose does not work the same for every patient. And this is exactly why pharmacogenetics becomes important. So we have genetic differences, of course, and this affects how our bodies handle drugs, especially at the level of drug metabolizing enzymes. So some patients are overall fast metabolizers. So they break down drugs very quickly, which can lead to lower drug levels, reduced effectiveness, even when they are taking the correct dose. Other patients are globally very slow metabolizers. So they clear drugs from their system more slowly, which can cause higher drug levels, increased risk of side effects, or toxicity at standard doses. Genetic differences can also affect the drug receptors. So some patients may be more sensitive to a drug, while others may be less responsive or even resistant due to the genetic variation in their drug receptor, even when the drug level is adequate. So clinically understanding pharmacogenetics can help us reduce trial and error prescribing, especially once you get to know your patient's typical response. So instead of guessing, sometimes we can better predict how the patient will respond. So ultimately, pharmacogenetics, and especially as it gets better and more used on a daily basis, will help us prevent toxicity, avoid treatment failure, and choose more appropriate starting doses. Patient genetics are one reason individualized therapy matters. So this explains again why the standard dose is not truly standard for every patient. Okay, so we're revisiting the CYP450 enzyme because it is the most clinically relevant pathway, the most clinically relevant drug metabolism pathway. So our CYP enzymes are our major drug metabolizing system in the liver. They are responsible for metabolizing a large number of commonly prescribed medications, which is why they are so central to drug interactions and variability in the drug response between patients. So one of the concepts here is that genetics strongly influences how active these enzymes are. Not everyone has the same level of CYP activity. So based on genetic differences, patients fall into different metabolizer phenotypes. So a poor metabolizer has very low enzyme activity. They break down drugs slowly, which can lead to higher drug levels and increased risk of side effects or toxicity. Our intermediate metabolizers have reduced activities, so somewhere between poor and normal. Extensive metabolizers are actually considered normal, and most dosing guidelines are based on this group. And then our ultra-rapid metabolizers have very high enzyme activity. So they clear drugs very quickly, which can lead to low drug levels, reduced effectiveness of the medications. So clinically, these differences among patients directly impact the drug levels, the side effects, the therapeutic response. CYP450 variability explains why the same dose can be safe for one patient, ineffective for another patient, and toxic for the last patient. So it's a very important clinical concept in pharmacology. Okay, so let's talk about some of the high-yield pharmacogenetic variants that affect prescribing decisions and patient safety. So first is CYP2D6. This is responsible for converting codeine into morphine, which is the active analgesic. So in poor metabolizers, this conversion barely happens. So patients get little to no pain relief even at the standard dose of codeine. In contrast, ultra-rapid metabolizers convert codeine to morphine very quickly, which can lead to dangerously high levels of morphine and overdose even at a typical dose. Okay, next is CYP2C19, which affects drugs like PPIs and clopidogrel, which is Plavix, a blood thinner. So in poor metabolizers, PPIs are broken down more slowly, leading to higher drug levels and prolonged effects. So for clopidogrel or Plavix, This reduced activation can lead to decreased antiplatelet effectiveness, which is important for blood thinning implications. Finally, CYP2C9, VKORC1 are very important in warfarin sensitivity, another very commonly used blood thinner. So with patients with genetic variants in these pathways, these patients will be more sensitive to warfarin, meaning lower doses are required. If you start at a standard dose and you're not monitoring this patient, they will have a higher risk of bleeding. So genetic variations will dramatically change drug response. And these are some of our most clinically important pharmacogenetic pathways for safety and effectiveness of medication. Okay, so HLA alleles and drug hypersensitivity. So these are genetic markers that would predict some severe skin reactions, like what we looked at in ClinMed. So HLA alleles are genetic markers, and these are when we're talking about these severe life-threatening drug hypersensitivity reactions, most specifically to the skin. Certain types of these HLA types are strongly associated with SJS and TEN. These are rare, but of course, as we talked about, extremely severe and very high morbidity and mortality. So one of these examples is HLA-B 1502. Patients with this allele have a significant increased risk of SJS and TEN when exposed specifically to carbamazepine. And so, of course, if a patient were to test positive for this, they would have to avoid carbamazepine, and that would be documented. Another important example is HLA-B 5701, which is a hypersensitivity to abicavir. That's a hard one to say. These reactions, so severe and potentially fatal reaction from taking that medication in these patients, but of course highly preventable if they get genetic screening. So because of these very specific, strong correlations that we know of, for these specific medications, especially in high-risk populations, genetic testing is typically recommended prior to prescribing. This allows clinicians to, prevent these terrible reactions before they occur. We don't have a lot of these types of testing that is actually done, but these are some specific examples that are typically recommended. Okay, so at this point, we've looked at how genetics affect drug metabolism, but genetics also play an important role at the receptor level. So genetic variation can influence the number of receptors a patient has, which affects how much response a drug can produce. So more receptors may increase responsiveness, while fewer receptors will blunt the effect of the medication. Genetics can also alter receptor sensitivity. So some receptors will respond very strongly when a drug binds, while others produce a weaker response even with the same drug concentration. Genetic differences can affect downstream signaling pathways. So even if a drug binds normally to a receptor, the signal inside the cell may be amplified, reduced, altered, all changing the clinical effect. And these are important genetic variants. Clinically, some examples would be beta-adrenergic receptor polymorphism. So this influences how patients respond to beta blockers. Some patients have a strong heart rate and blood pressure response, while others would respond less robustly. Similarly, serotonin transporter gene variants can influence the effectiveness of SSRIs in treating depression and anxiety. So that's why one SSRI will work well for one patient, but not for another. So genetics affect both how drugs are processed and how they work at their target, which is another reason individualized therapy matters so much in clinical practice. So when should you consider pharmacogenetic therapy? It's becoming more important tool, especially in personalized evidence-based prescribing, but it is not something we use for every patient or every medication. You consider genetic testing when starting drugs that are strongly influenced by genotype. So again, those classic examples are carbamazepine, where a certain HLA type predicts severe skin reaction, and warfarin, where genetic differences affect dose and bleeding risk. Testing is also helpful when a patient has an unexpected toxicity at a normal dose, or maybe the opposite, no clinical response despite giving the appropriate dose. So in those cases, genetics may explain altered metabolism or altered receptor sensitivity. This can be especially relevant when prescribing medications with a narrow therapeutic index. So narrow therapeutic index drugs where small dose changes can lead to toxicity, or when there is a family history of severe drug reactions. So that's why a really good history, specifically family history, can help decrease adverse events. Generally, most outpatient practices are not routinely going to order pharmacogenetic testing, but this is coming and it will be more common as time goes on. So this is something that is an important competency for you to know and will become more common as you get into clinical practice. So overall, our pharmacogenetic testing is an important tool for safety, but it still has some very real limitations. So it is not available for every drug. So we certainly cannot rely on genetics for all prescribing decisions. Insurance coverage varies, so that can limit the access for some patients. And even when testing is available, the results don't perfectly predict how a patient responds. So we cannot test every single genetic influence on drug behavior. Remember that environmental and clinical factors will still matter. So things like diet, drug-drug interactions, age, kidney, liver function, overall health of the patient. And so you would never use pharmacogenetic results in complete isolation, but they are one piece of data that will, in the future, especially be integrated into the full clinical picture. And so as a PA, the skill is basically knowing how to use genetic information thoughtfully as a guide, but not a replacement necessarily for clinical judgment. Okay, so let's try to apply this to a real scenario. So let's say a patient is started on citalopram at a standard dose, but quickly develops a significant side effect, such as nausea, dizziness, QT-related symptoms, those are cardiac symptoms, despite giving appropriate prescribing. And so this patient happens to be able to get genetic testing, and it reveals the patient is a CYP2C19 poor metabolizer. So clinically, this means the patient breaks down citalopram more slowly than expected. As a result, she gets accumulation of the drug even at a normal dose and the increased risk of overall adverse effects. So the important thing to remember here is this is not a drug allergy or non-compliance. It is more predictable. It's predictable pharmacokinetics based on her pharmacogenetics. So management would include reducing the dose or switching maybe to a different antidepressant that does not rely on that CYP2C19 for metabolism. So this kind of highlights how pharmacogenetics helps explain unexpected toxicity and more personalized prescribing. Okay, a few foundational topics we need to cover for this first pharmacology lecture, just as baseline. Okay, so the route of administration that we choose is based on two main things, the property of the drug and our therapeutic goal. So first, the property of the drug matters. Some drugs are water soluble, others are lipid soluble, some are easily ionized, and these characteristics determine whether a drug can be absorbed orally, whether it can cross membranes, whether it needs to be given IV or another route. Secondly, we think of what is our objective when giving this medication. So if we need rapid onset, such as a patient having severe pain or anaphylaxis, then we might choose IV or IM. If the goal is long-term steady treatment, then oral or perhaps a transdermal might be preferred. So sometimes we want to limit effects to a local site. For example, we talked about albuterol and our bronchodilators for asthma, or topical steroids for skin conditions to reduce systemic side effects. So clinically, choosing the route is not just choosing the right drug, it directly affects how fast the drug works, how strong the effect is, and how safe it is for the patient. So enteral administration refers to giving medications through the GI tract, most commonly by oral or sublingual route. The oral route is the most common. It is convenient, it is cost effective. However, absorption, as we already discussed, can be very variable. and is influenced by things like food, gastric motility, drug formulation. And then a key limitation is this first pass metabolism. So that is where the drug is partially metabolized by the liver before reaching the systemic circulation. So clinically, what this means is that oral drugs may require higher doses and may have a slower onset. Examples, of course, are like acetaminophen, amoxicillin, anything that we're taking by mouth, right? Again, I don't need you to know the specific examples because I think that's pretty common sense, but I would like you to look through, the absorption patterns, the advantages and the disadvantages. The sublingual route allows drugs to be absorbed directly into the systemic circulation through the mucosa under the tongue. So this route does bypass first pass metabolism, avoids destruction by the stomach acid, does have a very rapid onset of action generally. However, it is limited to drugs that are potent in small doses and drugs that can be formulated to cross the oral mucosa and to be absorbed in that manner. So if a patient swallows some of a medication that was intended to be sublingual, some of that dose will be lost. So we already talked about the classic example is nitroglycerin, where if it is swallowed, most of it will be metabolized and will not be effective. So clinically, enteral routes are choosing a balance between convenience for the patient, speed, drug stability, and the need to avoid first pass metabolism in certain instances. Okay, so let's look at parenteral routes, IV, IM, subcutaneous, all of which will bypass the GI tract. So intravenous or IV, of course, as we talked about, does not require absorption. The drug is going directly into the bloodstream. This allows for immediate effect, making the IV route the route of choice in emergencies, right? Or if we have very precise dose titration, also for drugs that are going to be absorbed poorly or that are large molecules like proteins. So the trade-offs are that IV drugs must be given very carefully. Of course, it has to be done under strict sterile techniques, so it does not allow a lot of flexibility for where the patient can receive the drug. And then, of course, errors in giving IV medications can lead to rapid toxicity. Intramuscular administration, which is typically injecting directly into the muscle, absorption is going to depend on the formulation. So aqueous solutions are absorbed fairly quickly, while a depot preparation is absorbed more slowly over time, which is useful for long-acting medications like hormonal contraceptive agents that are given in depot preparations or antipsychotics. IM injection, of course, can be painful, and we try to avoid IM in patients that have bleeding risks. So if they're on anticoagulants, it can be very painful and can cause a lot of bruising and bleeding under the skin. Okay, and then our sub-Q administration, this places the drug into the tissue just under the skin. Absorption, generally slower and more sustained. So this is ideal for drugs like insulin or heparin or epinephrine. However, not suitable for large volumes of medication because we only have so much space there, and also not suitable if it's a very irritating drug to that tissue. So it depends on how fast you need the drug to work, how long you want it to last. So this slide just kind of giving a visual of the different types of injections so you understand when we do learn how to do these, where the injection should actually be going, but also highlighting those intradermal injections. So that's injection into the dermis, the more vascular layer of the skin under the epidermis. Generally, these are used for your diagnostic agents like your PPDs and desensitization agents, so like allergy shots, for example. Okay, so next are our topical and transdermal routes. We often choose these to limit systemic exposure to the medication or to provide slow, steady drug delivery over a period of time. So topical medications can be applied directly to the skin or the mucous membranes. Absorption is going to be variable and is going to depend on factors like skin integrity, the surface area, inflammation in the area. Of course, major advantages for topical medications are that if we just need local effect, that is ideal, right? So antifungals, topical steroids we use for a local desired effect on the skin, and we minimize that systemic absorption. However, some systemic absorption can still occur, especially when we have damaged skin. So things like vesicles that are ruptured or cuts, and topical drugs may not be suitable in those instances. They also may not be suitable for medications with high molecular weight or poor lipid solubility because absorption will be affected. Okay, transdermal patches, these are designed for that slow, sustained systemic absorption. This has to be done on intact skin. These do generally bypass first pass metabolism, typically painless, very convenient for patients to use. It works really well for highly lipophilic drugs that are effective at low daily doses. So nitroglycerin, nicotine patches. Some of our disadvantages include delayed onset, skin irritation, and then we don't have a lot of drugs that actually fit into this category. So topical routes when you want a local therapy, while transdermal, choose when you want consistent drug levels over time and improved adherence. Okay, so what are some of our other routes of administration? Inhalation route delivers drugs directly into the lungs, where absorption, of course, is rapid because we have this large surface area and a rich supply of blood vessels. Inhaled drugs generally have a very fast onset, sometimes immediate. This route would be ideal, of course, for gases, for treating respiratory conditions, because we're delivering it right to the target organ. So again, we go back to our bronchodilators, our albuterol, our inhaled corticosteroids. A key advantage of inhalation is that it allows for lower doses compared to oral or parenteral routes. So that can reduce your systemic side effects. And doses can also be really easily titrated, especially in acute settings, like when we use a nebulizer. Downsides to inhalation, there of course is still some systemic absorption that not always desirable. This is a very addictive route because drugs can reach the brain very quickly, so that's just something to keep in mind. Proper inhalation technique is critical, so a lot of patients, you have to do very good patient education and they can struggle with the use, leading to side effects, underdosing, poor control. So inhalation is great when you need rapid action, localized lung effect, but patient education is very essential for effective use. Okay, so this is just a big picture slide of first pass metabolism and how different routes of administrations will affect it. So again, first pass metabolism refers to drug metabolism in the liver and sometimes the intestinal wall before the drug ever reaches systemic circulation. This is why many oral drugs have lower bioavailability. The drug is partially inactivated before it can exert its effects. So what this slide is emphasizing is that many routes bypass first pass metabolism either entirely or partially. Routes like sublingual, buccal, IV, IM, sub-Q, transdermal, inhalation, intranasal, and even rectal, depending on the location, can deliver the drug directly to the systemic circulation without going through the liver first. Clinically, this matters because bypassing that first pass metabolism is a faster onset, higher bioavailability, more predictable drug levels. And again, that is why nitroglycerin is given sublingually, naloxone might be given intranasally, and IV drugs are going to act immediately. So understanding this concept, if a drug bypasses the liver initially, it avoids first pass metabolism. That dramatically affects how the drug behaves. Okay, so this is just a quick summary slide of some advantages and disadvantages of the other routes that we talked about. Not going to read these to you, but they are part of those tables that we covered previously. Okay, so before we go further, I think it's important to be clear on basic dosing terminology because these words need to be used very precisely in pharmacology. So a dose is the amount of drug given at a single time. For example, 500 milligrams. Dosage refers to the overall schedule, meaning how much and how often the drug is given, such as 500 milligrams every 8 hours. A loading dose is an intentionally higher initial dose used to quickly get the drug into the therapeutic range. So this is helpful when waiting for a steady level of the medication would take too long. A maintenance dose is the dose given afterward to keep the drug level stable over time. Titration means adjusting the dose gradually based on how the patient is responding or tolerating the drug. So this is very common with medications that affect the heart, the brain, the blood pressure. These will all be tolerated based on patient response. And then therapeutic range is the plasma concentration where the drug is effective without causing toxicity. So safe prescribing, one of our main goals is to stay within the therapeutic range. So of course we have to make sure that we're specific about the drug form. If you're giving a medication orally, you want to make sure that you are letting the pharmacist know if you want the tablet form, capsule, solution, suspension. And the same goes for all types. If it's topical, is it cream, ointment, etc., etc. You have to make sure this is well documented on the prescription that you write. So for example, 500 milligram capsule will be taken orally 3 times daily for 10 days. So these are some of the common medication abbreviations that you will see constantly in orders and charts and exam questions. So first are units of measure. So milligrams and micrograms. These describe weight-based dosing. So milliequivalents or MEQ are used for electrolytes like potassium because they reflect chemical activity, not just weight. You'll also see milligram per kilogram dosing, especially in pediatrics. So weight-based medications and drugs with narrow safety margins. So this ensures that dosing is tailored to the patient rather than a one-size-fits-all. The next is frequency terminology, so abbreviations like QD, BID, TID, every 6 hours. These tell you how often the medication is taken, and understanding these is very important because errors in frequency can easily lead to underdosing or toxicity. And then route abbreviation, so PO, IV, IM, sub-Q, PR, topical, tells you how the drug is entering the body. And as you've seen, the route dramatically affects bioavailability and safety. So when we choose the dose, we're not randomly picking numbers. We are individualizing therapy based on the patient sitting right in front of us. So a few factors that will influence our dosing. Age. Of course, this matters because neonates and older adults metabolize and eliminate drugs very differently. So we can increase the risk of accumulation and toxicity, especially in those patients. Weight, again, especially important for drugs dosed per kilogram. So those narrow therapeutic margins. Organ function, particularly kidney and liver function. These have the major impact on drug clearance. Impaired function will often mean that the drugs will stay longer in the body. Comorbidities. This can change how a drug behaves and how well it's tolerated. So for example, heart failure, COPD, seizure disorders. And then drug interactions, which we're going to talk a little more about, can increase or decrease drug levels through enzyme inhibition, enzyme induction, or additive effects. So drug interactions are a major source of medication-related problems, especially as patients get longer and longer medication lists. So drug-drug interactions can affect how a medication is absorbed, metabolized, or eliminated. When this happens, the drug level will either rise, which can result in toxicity, or fall, which can result in treatment failure. These interactions are particularly common in polypharmacy, which is why we have to perform medication reconciliation at every visit. Drug-food interactions are another key consideration. So certain foods and herbal supplements, please remember that herbal supplements are considered a drug-food interaction. So for example, grapefruit juice, classic example, it inhibits liver enzymes and can raise drug levels. Timing with meals also matters. So calcium can bind with certain antibiotics like tetracyclines and prevent proper absorption. So we need to make sure that first we know which medications the patients are taking, which foods, and when they're taking the medication in relation to food, and of course, which supplements they are using. Okay, so we always, like I said, you have to make sure you're aware of any other complementary or alternative medications a patient may be taking. So some of our common complementary and alternative medications are herbal supplements, vitamins, acupunctures, homeopathic remedies. There is a lot of interaction risk with herbal products that that will affect your prescription drugs, especially your drugs with those narrower therapeutic index. So we always need to ask, do not assume the patient will volunteer. Oftentimes patients don't even consider that these would interact with their prescription medications. And then always be sure to use an evidence-based approach. So assess the efficacy and the safety based on your drug inserts and the current research. Okay, so I want to make sure to highlight the foundational principles of safe prescribing. So the 5 rights. You always want to make sure you have the right patient, the right drug, the right dose, the right route, and the right time. Most medication errors occur when one of these is missed. Clear communication is very important. So avoid unsafe abbreviations. Make sure to write legibly. This is not quite as big of an issue now that we have such electronic prescribing. And also eliminate things like trailing zeros that can easily lead to dosing errors. We talked before about the medication reconciliation, one of the most important safety tools. So verifying medication list at every part of the care pathway helps prevent omission, duplication, or any dangerous interactions that we may not have identified. Technology, of course, is a huge tool to our advantage. So barcode scanning, standardized order sets, and CPOE that will reduce human errors and improve consistency over time. And then as you get to the level that you're actually treating patients, there will be requirements for ongoing education and training. So because keeping in mind, like drug knowledge evolves over time. So we have to make sure that we keep current. That's one of our professional responsibilities. Okay, so when we write a prescription, there are certain things that have to be included. The indication for the drug. Why are we giving the drug? The dose, the route, the frequency, duration. We talked about these. You want to document if you counseled the patient on any specific patient education, any safety, any potential side effects, the monitoring plan for that medication, and also if you discussed with the patient any drug-drug interactions, drug-food interactions, take with food, that type of thing. Okay, and then this is just a typical sample prescription format. So typically we'll put the drug name, oftentimes try to use the generic, the strength, the formulation. The SIG includes the instructions. So that is the dose, the route, the frequency, and the duration. Dispense is how much you want the patient to have at that time. And then refills is how much you want them to have over time. So after 30 days, can they have 1 refill? Can they have 6 refills? Can they have 12 refills? The indication is always nice to put on a prescription, helps with insurance verification. And then, of course, if there's cautions or counseling that you want directly on the bottle or on the what's actually dispensed and given to the patient, you would document that on your prescription.